Thank you. Hi, everyone. My name is Maria, and I'm one of the endocrine regists. And today I'll be presenting this paper that was published in the Annals of Internal Medicine just in last month. So it's looking at preconception of the anti-diabetic drug use in men and any increased risk of birth defects in their offspring. So as we all know, diabetes is a very, very common condition, and it's becoming increasingly more common in people of reproductive age. We know that poorly controlled diabetes in pregnant women is associated with increased risk of adverse outcomes in pregnancy and also increased risk of birth defects. And that's why we advise diabetic pregnant women to have very strict glycemic control during their pregnancies. We also know that diabetes can be associated with poor sperm quality and impaired male fertility. And then thinking about medications, metformin is the first-line treatment for type 2 diabetes in terms of pharmacological treatment. And it can improve semen quality in obese men, but it can also reduce serum testosterone irrespective of glycemic control. So since it can have some effects on male fertility, the aims of the study were to look at whether exposure to anti-diabetic medication in fathers could have be associated with an increased risk of birth defects in their offspring. So they designed a nationwide registry-based cohort study that looked at 1.25 million births in Denmark from 1997 to 2016. And they looked at the rate of birth defects in those offspring and whether there were any associations with parental diabetes prescriptions and any other confounders.
This is all comers, not that everybody who was diabetic or not was acute.
All comers.
1.2 million births. Okay.
Yes. So the study was possible because in Denmark they keep such meticulous registries of various different healthcare outcomes. So the first thing that they did was to identify all of those births from the medical birth registry that basically notes every single pregnancy beyond the age of gestational to the 20th gestational week.
Maria, can I just interrupt? Sorry, one quick question. You mentioned metformin decreases serum testosterone.
Yes. So
is that known?
So they do reference a couple of papers, but I think it's controversial. And the discussion will also, I think, be quite controversial because they do reference papers that show that confirm the findings of this study.
Are there any diabetologists on this who have any thoughts on that or have come across that before?
I think Neil's on. I don't think Neil's online.
Yeah, I am, but I've not heard of it.
Okay. You would have thought it'd be the opposite, wouldn't you? As their inflammatory condition improves, the diabetes, and they lose weight, that perhaps their testosterone may improve.
That's what you'd expect from first principles.
It might be that their SHBG actually drops. It might be an SHB related thing, so they don't need such. No, I'll shut up. No, forget about that.
One of the problems of these, when they reference a paper, you can find poor quality papers that say anything. And that's a real problem, especially with all these journals that are springing up everywhere. Anyway.
Yes, I agree.
Yeah.
So once they identified this 1.25 million neonates, they then went to cross-reference with a patient registry. So each patient in Denmark has a unique identification number. So they're able to cross-reference patients across different registries. So they looked at the patient registry that basically has a summary of any diagnosis that the patient has had in either the outpatient or the inpatient department. So they will not have diagnoses that were made in general practice. So it might be that we are missing type 2 diabetics that are managed completely in the community. And then finally, they looked at the prescription registry to find prescriptions for diabetes medications that were filled by patients within the same time period. So they then tried to find any diagnosis of major birth defects in the offspring, and they used the EuroCat, so the European Concerted Action on Congenital Anomalies and Twins guidelines. So this is a 161-page document, but this is a summary of the major organs that they can look at and the major birth defects that have been noted. And the authors were particularly interested in genital birth defects specifically. In terms of exclusion criteria, so they didn't take into account any births that didn't have an identification number that could cross-link them to other registries. They also didn't include offspring of transgender parents or births that were actually stillbirths or multiples. And any offspring of women who had a pre-existing diagnosis of either diabetes or hypertension, or developed gestational diabetes, or if they had a mother who was taking either cardiovascular or diabetes medications.
So when you say omitted transgender parents?
Yes, so there's a flowchart later. So for example, a mom who carried a baby, that offspring was excluded, because I imagine that they don't know whether hormonally there might be some interference.
I can't work out how that's going to work. But anyway, let's move on. Okay.
And in terms of exposure, so we know that it can take up to 3 months for full maturation of the spermatozoa from when they are spermatogonia to then spermatids, and then full maturation in the epididymis. And therefore, the authors defined this sperm development phase, which is the 3 months before conception. And they looked at whether fathers in that 3-month period were taking any insulin or metformin or sulfonylureas. And then some patients were taking GLP-1 agonists or DPP-4 inhibitors, but in fact, the N numbers were so small that they didn't consider them any further.
So can I just ask how they know who the father is? I'm not being funny. What I really mean is, does the registry have both parents' details?
Yes, it does, exactly.
Okay.
So yes, another controversial, yeah. In terms of outcomes, the primary outcome was whether there was at least one major birth defect that was diagnosed in the first year of life. And then in secondary outcomes, they looked at organ-specific birth defects and also the offspring sex, which I think will be quite controversial later on. So they did a general analysis of every single birth they could find, but then if they found any birth defects within the anti-diabetic drug exposure groups, then they did 3 other more specific analyses. So one of them they called the time dimension. So for example, if they had a birth that was associated with exposure to metformin in the father, they looked at the time frame. So at how far away did the father take metformin compared to the conception? And they divided it into 5 different time frames. So more than a year before the sperm development phase, within a year of sperm development phase, within the sperm development phase, so 3 months, and then in the future, so after the sperm development phase, either within a year or more than 1 year.
But before pregnancy?
After pregnancy, which does not make sense. So I think the reason they did
That's
that—
a control group, I guess.
I think the reason they did that was because they then did some sub-analysis on siblings. So whether the siblings of the same father had different birth defect rates, depending on whether they were exposed or not exposed. They then looked at what they call the drug dimension. So they look at whether birth defects in specific anti-diabetic drug groups had different frequencies. For example, insulins versus metformin versus sulfonylureas. And then we look at this, what we call the sibling dimension. So basically it's what they call the within father sub-analysis. So the same father went on metformin at a specific time, and then they might have had a baby before they went on metformin and a baby after that. So they compared those siblings to each other. So this is actually the flow chart. So they start off with 1.28 million births that they could find from the register. They exclude around 4,000 of them because they couldn't find identification numbers. And then they start linking them to other spreadsheets. Then they exclude transgender parents, so fathers of female sex or mothers of male sex.
And that doesn't make sense. But fathers of female. and mothers are male. Why does the gender of the child make a difference? God, isn't it?
I think it's in a trans father of who's biologically the opposite.
Yeah, but it's just of the father's a female, so the female is the child.
But
This is fathers of female sex.
So that means the child is a female. So the
I think what it means is that if they were, before they transitioned,
yes,
if they were female, but they transitioned to a male, they still have female reproductive
yes,
organs and therefore can carry a child.
okay. That's,
However, they identify as a male. So that says fathers of female sex. So they are
a father, but
yeah,
they are
their genitals
biologically.
are female,
yeah.
but they identify as a father.
Do you think that's what it means?
I mean, they don't say in the paper. That's how they refer to them. So, but if it's the opposite sex, then surely it would be more than 20,000 people.
But how do mothers of male sex carry?
I guess sperm donation.
No, but if they're male sex, they don't.
I don't think it means that.
Okay,
I think
okay.
I think the child is the male. That's why I can't understand that. Why that whole box doesn't make sense.
Like the mothers of mouses, they're like transgender women, so they're not carrying.
But I think, but what does fathers of female sex mean?
It's a good question. You
And
know,
why would they exclude the father of the girl?
exactly. It is the mothers of male sex 7 is a odd.
It's
not
a very
huge
small number, yeah.
but also it's odd because I don't understand it.
Yeah.
Before they transition, don't they like freeze their sperm? So it could be one of
I
those.
guess,
Okay.
yeah, if they're transgender, I guess that, yeah, they would. Or I don't know whether if they stop their medication, then they can produce viable sperm and donate it.
But
then.
they're not necessarily saying that the mothers of male sex will carry the child. They're just saying that they've been excluded, correct?
Correct.
Yeah,
So actually, it doesn't matter what they carry. the child.
exactly. So as long as if you're transgender, you genetically
You'll
they
be
exclude,
because
exactly.
you can't negate the fact that you may have had it.
But you see, the reason it's important is I'm looking for bias, right? Because the logic doesn't make any sense, right? So I'm looking at my worry is that they've removed a whole group of people, and it's then what left behind is significant. I don't know, but that's a problem in it. But we'll keep going.
And then finally, so they then cross-link to the other different databases, and overall they then do a final exclusion if they're missing data. So for example, if they don't have a gestational age and therefore they can't calculate the conception date, or if they have multiple births, or if the mother had either pre-existing conditions or medications, those were excluded. So we end up with 1,116,779 births to look at. So this is the table of basic characteristics, which is quite busy. So we'll break it down. So looking at our control group, so the offspring of people who didn't have any diabetes exposure. So, and this is the vast majority of the births. So 1.1 million babies. So we can see that the median age of the mothers is at 30 years. The median age of the fathers is 32.5 years. And the frequency of major birth defects in the control group is 3.3%, or around 36,000 babies. And 51.4% of them were male.
That's about half.
Yeah.
Yeah,
Exactly.
I mean that's the problem is they made a huge deal about the difference. But
Yes, exactly. Exactly.
It's
And
weird.
actually, it's not significant.
Okay.
And then we move on to the births associated with anti-diabetic medication exposure. So those are 7,029 births. The vast majority of these children are exposed to fathers who are taking insulin, and then only 1,451 of them take metformin, and then 647 sulfonylureas, and 276 were taking other diabetes medications, and they were not considered at the analysis. So the first thing to say is that if we look at the demographics of the insulin group, they have very similar characteristics to the control group. So median age of the mother, 30.5, median age of the father is 33.2, However, when we move on to the metformin and sulfonylurea groups, we can see that the fathers are getting older. More of them have lower education, and also more of them have lower income.
That's
And
very
also-
interesting, isn't it? Is that just bias, or do you have a reason for that?
I'm not sure. I
Yeah.
guess,
Are these all
Poor-
type ones and type twos?
yeah, I guess there would be the type 2. So
Type 1 and type 2, isn't it?
yeah, so as
Oh,
in-
I see. So the types are
obesity
older. I
and-
got it. Okay, thank you.
and then in the oral medication groups, as we might expect, we have more of them are taking other cardiovascular drugs compared to the insulin group. And then indeed the insulin group were taking in turn more medications, cardiovascular drugs, than the control group. And then when we move on to see the major outcome, the major birth defects. So in the insulin group, this is the same as the baseline, 3.3%. When we look at the metformin one, that goes up to 5.2%. And when we look at the sulfonylurea group, that's 5.1%. However, when we look at actually at the numbers, we're talking about 75 babies. So even though we have a cohort of 1.1 million births, still our N number for the group that's very of interest to us is actually quite small. And then, because the authors will make a point for this later on, they say that the majority of these births were female births, but we're talking about tiny numbers. So 49.4 were male babies, whereas 51% of them were male in the control group and the insulin group. So they put all of this together to do a regression analysis in the male model, and they found after that the adjusted odds ratio for the insulin group was 0.98. For the metformin group, it was 1.4, so raised, and for sulfonylureas 1.34, so raised again. And then they did sensitivity analysis by restricting the group to other subgroups. So for example, only the children of mothers who were less than 35 years, of fathers that were less than 40 years, so on. And they found that this point estimates were actually not different. So all of the sensitivity analysis gave the same results. Then they...
Sorry, Maria, just go back to that. So when they restricted it to only fathers under 40, the confidence interval now crosses 1. So it's lost its significance. For the metformin group, it's now 0.97 to 1.94.
Yes, that's right.
So it's not actually now significant if you just look at fathers under 40, which would suggest it could just be a age.
Is that because there aren't many fathers under 40 with type 2 diabetes relative, or perhaps?
Well, it's 1 million.
Yeah, it's 1 million people here.
Oh yeah, okay. Yeah, sorry, well spotted.
So it could be an age thing.
That's true.
Yes,
Yeah.
they're not diabetes, quite right. A small number, very small number with diabetic. And,
Yeah, so actually we don't have the numbers for this particular subgroups. So there was some crossover. So in fact, up to 45% of men who were on sulfonylureas were also on metformin. But in the analysis, I think they put them, I guess, in both groups. So then they populated the model with other potential confounders. So what they present in the main paper is model 5, which is basically the year and then demographics of the father and the mother. And this is in the supplemental data. So what I found interesting was model 8, which goes through a pre-existing diagnosis of diabetes. And when we look at the adjusted odds ratios for model 8, we see that the metformin group has a ratio of 1.49, 1.43 for sulfonylureas, whereas in the insulins, that's not significant, 1 and 0.7. Then they took just 2,382 babies that were that had a father who had a diagnosis of type 2 diabetes, and then they separated that into fathers who have diabetes but are not on metformin, and fathers who have diabetes and they take metformin. And they found that if you don't take metformin, the baseline, so the birth defect frequency was the same as the control group, so 3.3%. And if you take metformin, that goes up to 4.6%.
So can I ask, in the general population here, what's the frequency of birth defects?
3.3%.
No, I'm just saying in the general population, because you've got diabetes not on metformin. What about people? Just generally.
Yeah, it's the control group, it was 3.3. So it's here, sorry, this one here.
Thank you.
And then they look at exposure to other medications, and they found that the adjusted odds ratio was significant only for if the father was taking beta blockers, and in fact the birth defects seen in this subgroup, actually the majority of them had a cardiac birth defect, but they don't give us any numbers. Then they move on to the time dimension analysis. So they look at just the birth, the offspring of people on metformin alone, and whether the timing of metformin could affect the frequency of birth defects. So we can see, if we look at the first line, the major birth defect frequency, we see that even if the father took metformin more than a year before the conception, we see that the frequency is 4%, and then as they get closer to the conception date, it goes higher to 4.4%, and then once we get into the sperm development phase, that goes up to 5.2%. They then also do analysis if the father took metformin after the conception.
Okay.
So as in retrospectively.
Yeah.
And then we see that it's 4.3% and 3.3%.
Now remember, that's a prescription, so he might have been taking it before by some other route. Or,
Okay, that's fair enough. Because I was thinking, first of all, is this 4.3% significant? We don't know, they don't say.
Yeah.
And secondly, if it is significant, is it because they are becoming pre-diabetic and I don't know,
Yeah.
or is it that they're taking it from without us knowing? But the odds ratio actually, in fact, is raised and significantly raised just for the 3-month sperm development period, and it's 1.75.
So
Then,
it could be, sorry, Maria, so it could be what you're saying. So if there's an increased incidence of, it could just be that their diabetes control is suboptimal around that time, and that's required a change in medication, like starting metformin or something.
yes, yeah, that's true, yeah. And in fact, one of the criticisms, I think, is that we don't have any information about the glycemic control of these people. Then they did this sibling or within father analysis, and basically what this table shows was that if you are an unexposed baby that has a sibling that was conceived at the time when your dad was taking metformin, your baseline birth defect risk is actually at baseline. So you don't have an increased risk if your father took metformin at some point in the past or the future. And the same if you're the child of a mother who has a partner who took metformin. So basically, unexposed siblings are not affected. And then they looked at organ-specific birth defects. So the first thing to say is that the two organs that seem to be the most affected are limb defects and genital defects. And then when we look at genital defects, the adjusted odds ratio goes up to 3.39. And in fact, the 13 babies that had a genital birth defect were all boys. And they all had hypospadias. So in summary, they found that exposure to metformin within the 3 months before conception significantly increases your risk of having offspring with birth defects, and that in fact the birth defects are most likely to be genital malformations. Having exposure to either sulfonylureas or insulin actually doesn't significantly increase the baseline risk for birth defects, and taking metformin outside this sperm development period again doesn't have an effect. And moving on to the discussion, obviously they found evidence that metformin can be detrimental to male fertility. So they mentioned some in vitro work looking at metformin and how it can reduce apoptosis in rat testicular germ cells. They found that male rats had altered reproductive behavior if they were exposed to metformin either in utero, if their moms were exposed to metformin in utero or during breastfeeding. They mention a paper about in vivo administration of metformin in pregnant mice, reducing fetal and neonatal testicular size. But of course, this is not recognized in humans.
Yeah.
So overall, this is their overall assumption, kind of conclusion, that the data on metformin and the specificity of metformin, but not sulfonylureas, to genital birth defects, and the statistical significance of the results suggest that metformin, but not sulfonylureas, is part of the observed association. So they also, in the discussion, they say that sulfonylurea-exposed babies have an increased birth defect, but that's not significant. So the p-value is not 0.107. So I don't even know why they mention this as they try to find a mechanism. They say that it might be that both metformin and sulfonylureas have a specificity, the drugs to spermatozoa. And then they have a whole paragraph about offspring sex. But if you read through the results, this offspring sex actually is not significantly different. So the 51% or 49% is not, it can just be random, just a chance. So then they talk about this scarring versus selection model, where if you have a very severe birth defect, then you're more likely to abort, whereas if you have a milder birth defect, you're more likely to have a full pregnancy and have that baby. And also they mentioned that it might be that the male to female sex ratio is reducing the metformin group, which is similar to other environmental exposures like dioxin. But again, so in terms of limitations for the study, so I think the most important one is that they didn't correct for diabetes state, so for glycemic control or HbA1c, and we didn't have any other information about other aspects of metabolic syndrome, so for example obesity, and also we only know about the diabetes cases that were on this patient register, which can be more severe, and that's why they saw a secondary physician, but also they might be better managed and therefore they might be actually better controlled. We don't know whether the medications and the prescriptions were actually taken. And also, I don't think in their modeling, they actually corrected for this socioeconomic status differences that were recognized in the basic characteristics of the cohorts. So after looking at this paper, my main question is, do we actually think that these results are significant, and are we going to, is this research going to change the way we manage male patients who want to have a family and who are on metformin? And therefore, if and then secondarily, if these patients do have increased risk of having children with increased birth defects, why is that? Why does metformin have a detrimental effect if taken by a father, but not when it's taken by the mom? And also, as Alex said, if we advise our patients to stop taking metformin for a period of a few months, that can have an effect and worsen their glycemic control, which can also have negative effects on pregnancy complications and neonatal outcomes.
Thank you.
So I guess this is quite similar to the flipping between PTU and carbimazole in pregnancy, you know, and periconception. You know, the argument that maybe it's best just to make sure their glycemic control is optimal rather than taking patients off metformin and trying to switch to something else because of some tiny risk, which is maybe not really there and maybe age related anyway.
Exactly, that's the problem. I'll tell you the problem, right? So the BBC News, I saw this through the BBC, which gave me a bit of a shock. And the headline was, metformin causes birth defects. So I clicked on it, and then I discovered it wasn't women. And then I dig deep before you discover it's about men. Because we discovered a lot of them PCO, I mean, a lot of metformin. I was really shocked when I saw the headline just says that without specifying the gender of the parent. So I thought, my God, this is big news. And then once I dug down, so it's got to the BBC and it's misrepresented. Because that's a bad headline.
Yeah, when I was looking at the online stats for the paper, it has 216 press
Yeah.
citation, like, or
Yeah.
hits, yeah.
And I think we're gonna have a bit of a problem because you identified this journal has an impact factor of 22.
Yeah,
Yeah.
it's a good journal. The referees have not done a good job.
Yes. That's the
Have you looked
conclusion.
at like alcohol, smoking, any other lifestyle factors?
I think the registries have maternal smoking and that's about it. So no paternal,
So many confounding.
yeah, that they haven't corrected for, yeah.
And the newspapers, I'm going to sell newspapers, so they do things like that, because that's made me look at it. If it said metformin got skipped on, when I saw metformin causes birth defects, I thought, I need to read this. So this is pure publication bias, isn't it? It really is.
But then they have such a rich database.
Yeah.
It's a pity that, I
Yeah.
don't know, like they
So-
could
so
have done much more with
They could,
it.
well, the other problem is they've done lots of analyses, and if you do lots of analyses, one of them might be abnormal by chance. That is the real danger. That isn't covered in the discussion. They don't say, we didn't correct for multiple, they use regression analysis, but of course, okay, that assumes that all those risk factors are independent, but of course, the minute you put someone on metformin, you might give them a beta blocker as well. They're not independent variables. The choice of making it is a doctor's choice, isn't it? They're quite likely to use more than one drug. It's a problem, this.
Yeah.
I mean, I have a horrible feeling there'll be a lot of people stopping their metformin. A lot of obese men will stop their metformin. And that's very bad, really. Because the BBC says it causes birth defects. I mean, it's a.
Has no one had any queries, patient queries, following this? Because we get them all the time in the bone clinic. I don't know, maybe we have a very well-read.
This is
Well,
just
fully
it's coming out. It will in the next few weeks. I bet you in diabetic clinic you'll start to see it. It takes a little while. It's only just appeared. This paper is like last week.
Hasn't made it to Daily Mail yet. That's when problems start.